Dr. Pratibha Singhal, Senior Chest Physician from Mumbai. My main forte is interventional pulmonology. I have been an ex-secretary of the European Respiratory, in the European Respiratory Society of the Pulmonary Intervention Group, as well as the Secretary of the Indian Association of Bronchology for 6 years. So my talk at APICON had been of EBUS, endobronchial ultrasound, its utility and clinical implications. So why EBUS? I mean, considering that this is a talk on general, most of the general topics, I just wanted to bring more awareness about this procedure, because in our country we are still not doing as many procedures as are indicated. So basic indications for endobronchial ultrasound are basically evaluation of mediastinal lymphadenopathy, whether it is for malignancy, staging of malignancy, for granulomatous diseases in cases of lymphoma, or sampling any lesions that are around the airway, whether it is mediastinal lesions, whether it is bronchogenic carcinoma, or any bronchogenic cysts. So how is an EBUS scope different from a regular bronchoscope? The EBUS scope has a linear convex probe attached to the tip, and therefore when you abut it against the wall of the trachea or the bronchus, you can see, you have a real-time imaging available of what is happening outside the bronchus. So when you're passing in a needle to take your biopsy, you are obviously not going to puncture any blood vessels, and therefore the complication rates are low. Less incidence of puncturing the lung, because you can measure the size and the direction of the needle that is going to go. So therefore again less complications. Now why staging of non-small cell carcinoma is important? Because as we know now, over the years, PET-CT picks up metabolically active lymph nodes, and these lymph nodes in our country can very well be granulomatous disease, because we are endemic for tuberculosis. So it is important to differentiate presence of PET-positive non-malignant lymph nodes, because that will change the staging in lung disease, as well as positivity if it is in extra lung malignant metastasis. So we have had patients, especially in our country, where the incidence of a PET false positive has been higher than 24 to 25%, almost sometimes in some amalgamated series of to the tune of 30%, which basically means that whatever is PET positive in a known malignancy is not malignant, and therefore it is important to sample this. Even the ACCP guidelines are now recommending that anything that is PET positive should be sampled with tissue, and endobronchial ultrasound for lung non-small cell staging has been proven to have 89% sensitivity in TB. In TB also the sensitivity is high to the tune of 80 to 90%, and specificity is also high. So basically in our country, why we are talking about TB is because we have a lot of extra pulmonary TB, like when you have mediastinal tuberculosis alone, and also the incidence of drug-resistant TB is on the rise. So starting empirical AKT is not right, and we must sample these lymph nodes and get a proper diagnosis, because we've had patients who have been put on empirical anti-tuberculous treatment and then later been referred to me, and then we have found that these are actually cases of drug-resistant TB. Similarly, sarcoidosis, again a disease which is reasonably prevalent in our country. EBUS sampling of the lymph node is an important tool in diagnosis. And lymphoma, slightly lesser yield, but yes, it still forms the primary portal of sampling the mediastinal lymph nodes. Sometimes when you have peribronchial tumors which don't have an endobronchial component when you're doing a bronchoscopy, and there is lung disease, so you're not going to be, not a good idea to do a CT guided biopsy because of high incidence of pneumothorax. Again, doing an endobronchial sampling here for diagnosis is important. So the thought always, and the question always comes to everyone's mind, that why are we not using it so frequently in India, though it is a standard of care now in diagnosing and in staging mediastinal lymph nodes, whether it is diagnosing non-malignant lymph nodes, granulomatous, TB, sarcoid, or other disease, or even just cystic mediastinal cysts or bronchogenic cysts. The issue that comes usually is people have this fear that it is expensive. But please remember that there are many advantages when you do an EBUS procedure versus doing a CT guided biopsy, which yes is cheaper, but then there you can sample only subcarinal lymph nodes easily. Even hilar lymph nodes and paratracheal lymph nodes are not easy to sample. You have a high probability of a negative yield and a very high incidence of pneumothorax. Secondly, these complications are less when you do an endobronchial ultrasound. Also remember that you can look at the endobronchial tree. You can also do multiple samplings at the same time. If you find something endobronchially, you can biopsy that as well. You can do a transbronchial biopsy as indicated in the same sitting. So multiple procedures can be done when you are doing a bronchoscopic sampling with EBUS versus doing a CT guided sampling alone. So here in bronchoscopy, you will be able to sample the primary lesion plus do a staging at the same sitting. So that is what I would like to basically recommend, that slowly as we start doing increased number of procedures, our cost will also go down, because obviously it all depends upon how much. These are slightly expensive instruments, as we all know. All advances in technology which come initially are expensive, but the more we start using them, the more the cost burden is going to come down. So I recommend, please, let's start using this technique judiciously and more often. Thank you.